All right. Going to talk about intubation. This is out of Chapter 33 from Egan. And there are some labs that are associated with this. But we're going to kind of, again, tie together endotracheal intubation PE with the cuff measurement PE. And lots of websites for this if you want to review or not. But again, talking about the same kind of things we've been talking about previously. The best solution for unruly patients. You know what? We can walk through. We don't need a video. It's about a 15-minute video from the New England Journal of Medicine. It's like, oh, this is painful. So, key parts to an endotracheal tube that you will need to discuss and know about. First off, a standard 15mm adapter that will attach to any type of resuscitation equipment, be it a manual resuscitative bag, be it a mechanical ventilator circuit. They're all standardized to fit on that process. Along the side of the tube, there are markings that are every centimeter depth from the tip. So the distance from here to here is noted by that number. Okay, and when we have this placed inside the patient, all you see is this. So you'll say it's at 22 at the lip or 24 at the lip, and that's the marking that we want to have to tell where that tip is located, because we want the tip obviously above the carina and the cuff below the cords. So it's got to be placed in the proper spot. There's a pilot balloon which is attached to the cuff. The cuff is a high volume, low pressure cuff. That's very important because they did make low volume, high pressure cuffs at one point in time. And obviously that cuff pressure is transmitted across to the tracheal wall. So we're going to find that we want to monitor that cuff pressure and keep it at a level that is safe. And the last feature here that you end up having is this blue line that, once it's in, is going to give us an index of where that endotracheal tube is placed. Because it's a radio-opaque line, and a chest x-ray will show up and show where the depth of the tube is at. Okay? Why do we intubate somebody? First of all, and these are classic definitions, airway compromise. Somebody who doesn't have an intact somebody who airway is compromised. So for instance, if I have a patient who was in a fire and had hot steam in the environment and has an airway that is inflamed, intubation may be indicated. Somebody with epiglottitis, that airway can be compromised through the swelling. So I want to intubate. Need to protect the airway. I just realized there should be a fourth one here, but okay. Need to protect the airway is somebody who, for instance, like a stroke victim, who doesn't have an intact, good airway protection mechanism on their own. Drug overdose patient, who's in and out of consciousness and in and out of the ability to have an intact gag reflex. Add to that list, although it's kind of tucked under that need to protect airway, facilitate suctioning. Yes, ma'am.
I was just wondering, when people have seizures, I've heard this, don't know if it's true, they can swallow their tongue?
No.
Okay.
Their tongue becomes obstructive.
Okay.
So, and really the key part with that is not so much fighting them as making sure that they don't protect them so they don't hit something. Though in almost all cases they're able to ventilate to some extent, and if not, they pass out. They come out of the seizure. So if their CO2 builds up high enough, but it's just mainly just protecting them. Often they'll bite on their tongue, and that can lead to some problems as far as bleeding and whatnot. But for the most part, seizures are just got to wait out the brain's activity until it calms itself down. Okay. So facilitate suctioning. If I have somebody who has tons of secretions, has an ineffective cough, technically that's an indication for intubation. You won't see a lot of 85-year-old patients with lung cancer who can't manage their secretions be intubated, because it's kind of like, well, maybe this is nature's course. Maybe you might, Nancy, you're right. She's in her back going, yeah, right. Happens all the time. But that is technically an indication for endotracheal intubation. Kind of falls under the need to protect, although it is technically separate. And the fourth reason is that you will have somebody who's in respiratory failure that you need to mechanically ventilate. In theory, with non-invasive ventilation, you might be able to bridge until we can stabilize the patient and not have to intubate and mechanically ventilate. But if you have somebody who needs high ventilatory needs, high levels of PEEP, you will need to intubate them and mechanically ventilate them. Okay? Please, please, please do not confuse intubation with ventilation. Okay? I can do ventilation without intubating, not invasively. Facial CPAP, yeah, but again, that's not ventilation, that's just maintaining a positive pressure. Bag valve mask ventilation, sure, another example. I can intubate and not need to ventilate to protect the airway. A lot of physicians will, you know, can we pull the ventilator from this patient's room? They're breathing spontaneously fine. Well, no, he still needs to be intubated. I didn't ask that. You can have the patient's airway protected because he needs it protected, but you don't necessarily need to have the ventilator there. They are two distinct things. Okay? Does that make sense? Mm-hmm. And it will make more sense as you go along and you're going, why is this vent still on the patient? Do you have a question, Allison, or are you just airing out your...
No, talking about like epiglottitis, right?
For airway compromise, yes. Oh, and then there we go. I guess I did break these down. Anything we didn't say that makes sense. Congenital anomalies. Okay. Bleeding. Talked about the loss of gag reflex. And there's mechanical ventilation instances. When we talk about the indication for mechanical ventilation, some are pretty obvious. Apnea. Yeah, that'd be a good reason to ventilate them. Unless it's your mother-in-law, you don't like her. Patient who extubates themselves and needs to, but can't ventilate on their own effectively, we need to re-intubate them. Okay. Some of those are more obvious as we get into mechanical ventilation. So here's a mini clinic out of Egan. Patient admitting to the emergency department for suffering chest trauma during an MVA. Unconscious cyanotic tachypnea, has blood in his mouth, her mouth and pharynx. Breath sounds are diminished on both sides. Physician requests that you immediately perform oral tracheal intubation. Is there an indication there? If nothing else, loss of consciousness. Blood in the mouth and pharynx, showing that there's potentially some areas that need to protect the airway. Chest trauma, probably going to need to be mechanically ventilated. Okay, so classic indications for airway management. Oh, look at that. There's their answer. Again, this is the algorithm we looked at previously, but here's the intubation component to it. So if they're in a situation where CPR is going on and it's not something which is going to be easily converting, we can go ahead and intubate the patient. 31-16. When do we not intubate? When is it contraindicated? When it's been expressed clearly by the patient, and it is something which should have a specific notation in their chart. Either in their what's the word I'm looking for? Advanced directives, or in the case of their durable power of attorney for health care, that person has said the patient did not wish to have that going on. So do not resuscitate, do not intubate. I always love the situations where they want a full code on the patient, but they don't want him intubated. I don't know how I'm going to manage that one, because I've been in situations where they've got the pulse back and I'm breathing. It's like, let me stand and do bag valve mask ventilation all day? So, not always right. looking at complications and hazards associated with endotracheal intubation, there's a couple different phases that we can talk about. At the time of intubation, while it's in place, while we extubate the patient, and then in the post-extubation period. So let's take a look at some of those as we go along. The time of intubation, complication would be that we are taking too long and we can't establish a patent airway in the meantime. And they become hypoxemic, exactly, and hypercarbic. Another complication would be an unrecognized esophageal or bronchial intubation. So either you don't have it in the trachea, it's in the esophagus, or it's in the trachea, but it's pushed too far and into the bronchus and not being recognized. Trauma, as we go through the procedure, you'll find out that it is indeed something which can induce significant amount of trauma. And we'll talk a little more about that. Aspiration, not only of a tooth which you have knocked loose, blood which you have created, the bulb from the laryngoscope blade, oops, and certainly vomit. So there's all kinds of things that could go wrong during the procedure. This is really unrecognized problems that are with the airway prior to the procedure beginning. It's going to complicate the ease with which intubation happens. Perforation of esophagus or the pharynx. What are you doing? Good God. Again, these are just listed as such. Hypoxemia, I will tell you, is a very common occurrence, and that's why we pre-oxygenate the patient prior to the procedure beginning. You can have tachycardia from an adrenergic stimulation. You can have bradycardia from a vagal stimulation. So both are possible. Increased intracranial or intraocular pressure just from the patient trying to fight against you, and then laryngospasm or bronchospasm as a complication also. So there's lots of things that we have to keep in mind while we're doing this procedure. Once it's in place, there's some complications also. Tension pneumo. Why would you have tension pneumo from the tube being in? Yeah, I'm ventilating with too high of a pressure. It's a whole lot easier to ventilate with a higher pressure with the tube in. What would happen if you tried to let's say we're doing bag valve mask ventilation and using excessive pressures? Would I necessarily cause a tension pneumo? Yeah, gastric distension. It's where you push gas into the stomach because it's opening up the esophageal sphincter. Whole lot easier to do that than to go into the lungs. Okay. And if I'm putting gas in the stomach, those of you who have children, what happens to that the stuff in the stomach? They barf it up. That's right. And in a case of someone who doesn't have a good protected airway, what's going to happen? They're going to aspirate it. Sure enough. Accidental extubation can happen once the tube's in place. So in other words, the tube is placed. Think of your little neonate, how small an endotracheal tube is and how small their airway is, and they just go with their head, and the tube pops out. Very easy to dislodge, especially in the smaller ones. Tracheal tube fire, that's a good one. That's a good one. That's more associated with OR and when they're using laser for some procedures, especially some laryngeal procedures. And the laser with a high oxygen environment can induce a small fire. Seals are an issue, both from the sense that the cuff itself gets torn. Think of the people who have these ornate oral appliances, bridges, crowns that are not smooth. As the tube is going in, that cuff on the end catches on there and rips. And you find this out when? After it's already in. Wonderful. Got to remove the old tube, put a new one in. Cuff herniation means that the cuff itself, if you can think back to where that cuff was located, it's recessed back from the tip of the tube, but if it doesn't inflate uniformly, it can actually go over the end of the tube. That's called cuff herniation. Herniates, moves itself right over the end of the endotracheal tube. Pilot tube valve incompetence. Mary will talk a little bit about that in the fall, but there's a pilot balloon there that is allowing you to inflate the cuff but not allowing air to leak back out. Well, that'd be a good idea. You want the air to stay in the cuff. That pilot balloon can get damaged. And when it gets damaged, it leaks, which means I can't keep air in the cuff, which means I continuously have a leak. Not a good thing. Yeah.
What was that?
The cuff itself shifts itself so it's over the end of the endotracheal tube, where the gas would normally, that's herniation. Cuff perforation just said that it tears. Yeah. Why couldn't I say that? I've seen patients move their tongues to the extent that they've pushed the tube up out of the trachea and they swallow it. Not that it goes all the way down, but now I'm getting air in the stomach. I'll tell you one little lady I saw, Mrs. Wong, I remember her very well. She was all of probably 4'2". She was a little Chinese lady. And she's lying in bed, and I was walking by the room, and I see her toe come up and grab her on the tracheal tube. Little contortionist lady. It's like, yeah, we had our arms secured. She was going to get that tube out. And the bottom group there, certainly there's always the possibility of, once the tube is in, it becoming obstructed in some fashion. Either the tube itself kinking. Remember, this is a hard piece of plastic, but you warm that plastic up by being inside your body, that tube becomes quite malleable. And you can get situations where it kinks itself off, especially small pediatric tubes where you're putting an HME, a closed suction system, all this other stuff attached to the end of the tube. It's very easy to kink it. Biting on the tube, we talked about using some sort of a bite block. And an occlusion of the tube from mucus plugging. Some real horror stories out there of inadequate humidification. And boy, you know what? I can't get a suction catheter down my endotracheal tube. Why can't you get it down? Because it's become crusted on the inside. In fact, I've seen tubes pulled out where, you know, your tube is probably, you know, this long, 10 inches or whatever that is, and then about 2/3 of the tube itself has this small little passageway where just the suction catheter could fit through because it's all corroded on the inside from inadequate humidification.
Bert, can you go over the pilot tube valve incompetence?
Let me hold off on that, and when we get in the lab, remind me, and I'll show you because it's probably easier to see. Basically, there's a it's not a spring-loaded, but it's like a spring-loaded valve that allows you to put air into the cuff, but doesn't allow that air to come back out unless you physically pull it back.
Okay.
That mechanism can become damaged.
Why would you want to do that?
Why you wouldn't want to, but if it did,
Oh, okay.
if it did become, if that pilot tube valve becomes incompetent, if it becomes cracked, you get a leak.
Okay.
There are patients who are difficult to extubate. You wouldn't think that would be a real big problem, but there are problems that can develop. Once a tube is in, especially if they're in for a length of time, you can end up getting a situation where that endotracheal tube develops granulomas around it. So the skin, the tissue itself actually starts to harden, and that can actually lead to problems removing the tube. You can get a situation. I've seen this happen more than once. A lot of people will take that pilot balloon that was there, and to extubate it, I just cut it. Just cut it, right? Here's my pilot balloon, right? I attach my syringe here and I inflate the cuff. Well, to deflate it, why don't I just cut it? Why? The problem is what is going inside this to here? It's air. Is air humid? Air has humidity. When you put this in, what potentially can happen is as the body warms, that air humidity becomes water, and you end up with a lock, an airlock. You can't pull it back or push air in anymore because there's water sitting in there. So if I cut the pilot balloon, the thought is, oh, the cup's deflated now. Oops. It won't deflate. So this, now inflated, is coming through the vocal cords. That's why it's always good to use a syringe and deflate it. That's a weird one. Laryngeal edema, obviously. Got a lot of swelling there. And potential for aspiration happens. And then really the big one is the one after the tube has been removed. And there are some institutions in the state of Michigan where respiratory therapists intubate at a code or at some point. Most of the time, most institutions haven't granted us that privilege. However, we pretty much always extubate, which begs the question, if I can take the tube out, what happens if one of these things happen and I need to put it back in again? I got to call somebody. That's a wonderful thing to do. In the meantime, what do? Try to bag the patient. I will tell you, if you go outside the state of Michigan, it's expected that you intubate. So you will get the training to do it, whether or not you actually utilize it. Oh no, there's a couple. So, sore throat, obviously. Has anybody ever been intubated, by the way? Did you have a sore throat when it came out?
Yes.
Yes. Laryngeal edema, some hoarseness of voice. Theoretically, you can develop some nerve damage, some recurrent laryngeal nerve damage. Ulcers, granulomas, all kind of oddness involved. Further down, above or below the larynx, you can also have some tracheal wall damage. A couple of them I want you to know is the tracheal stenosis, meaning what? Narrowing of the trachea. Tracheomalacia, which is the softening of the cartilage. So what you end up having is the trachea on inspiration, make sure I get this right, on inspiration moving inward and on expiration moving outward. Because the wall moves, there's no cartilage supporting it. That's tracheomalacia. You don't need to worry about which way it's moving, just recognize that it moves. The walls don't have support. Well, think about it. When you breathe in, what kind of pressure is inside your trachea? Negative, right? So if I had a negative pressure inside my trachea, which way is the tracheal wall going to move? Inward. If on exhalation I have a slight positive pressure, so which way is it going to move? Outward. Bottom line is that tracheal is moving. Tracheoesophageal fistula. Not a blocking. It's a connection between the trachea and the esophagus. Posterior wall of the trachea and the anterior wall of the esophagus are contiguous. You can erode a hole between them. Oops. Not a good thing. The last one I just want you to be aware of, tracheal innominate fistula. Ever hear of the innominate artery? You can have a situation where the tube itself, the trachea, is actually pushing against the innominate artery, and the wall of the cuff itself can cause an erosion between the trachea and the innominate artery, and you have massive hemorrhage.
Where's the amount of
It's a branch of the brachiocephalic. It actually is the brachiocephalic, to be honest with you, Kim. Kim, it is the brachiocephalic. Just another name for it. Where you will see this, or the thing that I want you to keep in the back of your mind, if you feel the endotracheal tube pulsating, that's a sign that this may be happening. Okay? Definitely something to bring to someone's attention. Because it's up butting against the artery, you're feeling the tube actually pulsate. You see it more with tracheostomy tubes than you do with endotracheal, but the potential is always there, especially if the trach tube is not placed appropriately. Right, but it can still erode out because the pressure was there. More, it happens when the tube is in when it's a trach tube more, but right. Yeah.
Erosion is caused by pressure?
Yes. Yes.
What's the laryngeal? I don't know.
Don't worry about it. Those are weird anomalies that you'll end up having. There's enough pain without having to introduce more.
There's not a certain time limit that you can,
Leave the tube in.
yeah, so it doesn't cause the,
Oh, you want to get a real good debate?
I guess not.
That's the standing. That's a world-class debate. How long do you leave an endotracheal tube in before you tracheotomy? Before you trach?
Take it out to put a new one in, you know, that will keep it from,
Well, but the pressure is still being placed against the tracheal wall. Even if you change the tube, you still have cup pressure.
you know, you wouldn't have that tissue going around it like in a one case.
Well, those are more rare occurrences. Probably the biggest problem is the cuff eroding. Yeah. You okay? All right. So why? I mean, this doesn't sound like a real good thing to intubate somebody, but it's probably the most common way that we end up managing the airway. There's also some other problems just from endotracheal tubes being in. You obviously, like as I mentioned about the humidification, you got to provide adequate humidity. And we'll spend a little bit of time talking about the different ways to humidify inspired gas and how some of them are not always as effective as you would like. And that's where you end up with those mucus plugs developing. You're also not filtering gas, so you have to make sure a filter's in place. Loss of ability to effectively communicate. First of all, you now have a tube inside their vocal cord, so they'll never be able to speak, despite what you see on General Hospital and Days of Our Lives. Okay. More importantly, you can't read lips really easily. You'll get good at reading lips as far as what patients are trying to say, but it's hard when you got a tube sitting in the way. It's difficult to do. People will give patients a clipboard and a pen and try to have them write out what they're saying. Go home and try writing like this. It is very ineligible, not ineligible, that's what I'm looking for. Unintelligible. You can't figure out what the heck they're trying to tell you. A lot of times we use letter or picture boards. You know, I'm hot, I'm cold, and they can point at a picture. Kind of poses a problem when your patient doesn't have a high reading skill. It's not a you can't read what they're looking at, but that's why they're pictures in the sense. Can't do a Valsalva maneuver because you can't generate pressure because you got an open connection. Can't cough. No. Sense of smell and sense of taste, especially with really an endotracheal tube or a tracheostomy tube. When you smell, when you get a nice steak and it's, you know, that nice charred, you have to smell it. You can't, when you have an endotracheal tube in, you can't move air in that fashion. Well, I guess you can sit there like this. But because you can't smell, your sense of taste is altered also. Everything's bland. Am I right, Matt? Matt's nodding his head over here. So.
Mine was from surgery because I was under for over 6 hours. I actually went to the 12-hour mark. So they had to intubate me. They did it before we went in. So I was freaking out and I couldn't stand being tied down. Because even being aware of it, the first thing I wanted to do was
pull it out. And that's very, very common. But even when patients wake up from anesthesia, the first thing they want to do is rip that tube out. Well, it may not be good time to take it out just yet. So, lots of supplies that we'll need to intubate somebody. Some of the stuff is pretty self-evident: personal protective equipment, a stethoscope to verify proper placement. Always, always, always have resuscitative equipment handy unless you feel like doing mouth to tube. We will go through the process of selecting a tube and handle and blades, having spare equipment, use of a stylet. McGill forceps we don't utilize that much anymore because McGill forceps are for nasal intubation, and we rarely, I haven't seen a nasal intubation in a long time. No. So, probably will not need that. We talked about water-soluble lubricant or xylocaine jelly. 10 milliliter syringe, and we'll talk specifically a little bit more about the syringe in a sec. A suction kit. What? Yeah, suction kit. One of the things we'll do when we first intubate somebody is we'll go ahead and we'll suction them and get a sample at the very first moment. So that way we can see what is colonizing the airways at the beginning. CO2 detector, pulse oximeter. Mary talked about those, I'm sure. And some mechanism to secure the tube to the patient's face. Usually tape works fine. And we'll go. So 2 types of tubes, oral and nasal. They're really the same tube in a sense, but the nasal is a little bit longer because of the passage you have to go through. Oh, labeling. What's A? What's B? You got them written out on yours? Yeah. Why am I wasting my time then? C is where we're going to have that pilot valve. There's my beveled tip with my Murphy eye. Can you see the Murphy eye? Probably not real well, but it's right there. E's my cuff. F's my radiopaque line. I have some test markings on there that I'll talk about in a sec. Distance markings from the tip, internal diameter, and a 50 millimeter adapter. Okay, they're made out of typically polyvinyl chloride, although there is some tubes being made out of silicone also. There is standards that you should be aware of, if nothing else, the letters that are named, they're there. There's a subcommittee of the American National Standards Institute, ANSI, called the Z79. If you pick up a tube, you'll probably see the letters Z70, letter and number, Z79 or ANSI stamped on it, meaning that the standards of manufacturing that tube comply with these standards. Okay. You may also see something. I'm sorry. One of the things that the ASTM or ANSI also stated, they say there's certain labeling that should be on there. Depth markings. There should be a radiopaque line. There should be a cuff that is able to easily inflate and deflate. Blah 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 blah. And then you may see a letter called IT, and that stands for implantation testing. What they want to make sure is that they go ahead and make sure that the plastic being utilized is not toxic to tissue. So they take a small piece of that plastic and they implant it into a bunny rabbit, and they see if the bunny rabbit dies. So here are some of those guidelines. Again, it has to have the size of the tube on it, has to have a 50 millimeter adapter, has to have a Murphy eye, blah, 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 blah. If you think about what a tube looks like, they're standardized for that purpose. And that's really all I want you to know is if you see Z79, that's what it's talking about. This is just looking at the difference between a pediatric airway and an adult airway. You can see how the anterior and posterior walls fit and how the cricoid is the narrowest part on a pediatric patient. Pediatric patients typically are uncuffed. They use that fact that that cricoid cartilage is a small area to have a tube just slightly smaller than that cricoid. They actually have cuff tubes all the way down to 2.5 now, but normally it was anything below 5 you could pretty well guarantee wasn't cuffed. You will not need to know this, but it's great trivia. This was an alternate form of endotracheal tube called a Cole tube, and it was designed to actually slide into the cricoid and ram into it and seal it that way. It's a little bit of a sadistic mechanism. Stylet. A stylet is a rigid piece of metal or plastic that is curved typically, or can be bent to make it curved, so it allows some form fitting for the endotracheal tube. So a tube's a piece of plastic. It never fails. You're visualizing the laryngeal structures, and the tube keeps going down below into the esophagus. Damn. So if I have a tube that's a little bit more rigid, it's going to follow the direction that I'm pushing it in. Key part, where's the stylet? This is actually not a good diagram. The tip of the stylet should not exceed out the end, obviously, and should actually be recessed back behind the Murphy eye. Because what you don't want is you don't want this piece of metal snaking out of there, and as you're putting it through the vocal cords, do some damage to the vocal cords. Am I making sense? Probably make more sense once you get your hands on it. There's our McGill forceps. They're like scissors, only as you open and close them, they basically open and close the little alligator parts on the end, so you can grab stuff. And this is the nasal intubation process we're not going to worry about, but as a tube is going through the nose, comes out below the uvula, I can grab the tube and direct it up towards the trachea. We know about laryngoscopes and blades. There's 2 types, a straight blade and a curved blade. The curved blades are like apples, so they're called Macintosh. Actually, it's not true, but they're curved, so they're Macintosh. Straight blades, there's a bunch of different brands. The majority of them are Miller's or Wisconsin's, and you'll end up seeing them as you go along. There's a uniform handle that will fit both blades with batteries on the inside. There's an indentation on the blade and a little bar on the handle. You line the 2 of them up and click it up, and the light will go on. So here I'm attaching it, locking it in place, pulling up to a 90-degree angle, and the light comes on. Which blade you use, or which blade that someone who's intubating uses, is strictly preference. If you learned on a Mac, you'll always use a Mac. If you learned on a Miller, you'll always use a Miller. Theoretically, you should be able to use both, but strictly preference. Yeah?
If it was a baby though, don't you have to use it?
Because they don't have a well-defined epiglottis, it's very floppy, and their vallecula is not really well-defined either. Straight blades are used for that purpose. In theory, you can look at the size of the individual's hand to determine the size of the blade to be used. But basically, smallest is a 0, and that would be with the premature. And you can see as you go up in age, you go up on the size of the tube itself. And this is kind of a bogus thing because it shows only Macintosh. You can use Miller's. Probably a Miller 2, Miller 3. There actually is a Miller 4 also. And then you can probably visualize duodenal tissue with that if you go in far enough. Do we have a 4 over there? If you want to intubate a horse, maybe you would need something that large. Key part is what happens if when I do that flip up, the light doesn't come on. Okay. One, make sure that you have the right blade for that handle. They are universal, but there are a couple of brands that are specific for it. Make sure the contact is good, that you don't have it. Sometimes if you don't pull it to a direct 90-degree angle, you don't quite get the connection there. The bulb may be loose. This is where I was talking about aspiration of the bulb. Oops. Batteries could be dead, or they could just be put in incorrectly. The blade itself could have a bad connection somewhere internal to it, and the bulb could be dead also. So lots of little things that you could be the reason why the light doesn't come on. And that might make a great multiple, you know. Is that a groan? Okay. Remember that this endotracheal tube selection you want to choose is dependent upon Poussin's law. Remember back to Poussin's law, diameter, the radius of the airway, it was one of the largest components that dictate airway resistance. For a pediatric patient, you can kind of use their small finger. Adults are fat, you can't do that with them. But there is a rough way to be able to estimate, and this is pediatrics. I'm not going to make you memorize this if when in time comes that you go work neonatal or a pediatric hospital, you can commit it to memory at that point in time. But roughly, you can take the age in years minus the age divided by 4 and get that for what it's worth. Or you can carry around this wonderful chart. Rough rule of thumb, and this is what we'll kind of go with because we're looking at the internal diameter, right, guys? 7 to 8 for a female, 8 to, well, yeah, 8 to 9 for a male. It might be a little bit large. Oh, those were ACLS numbers. What do you probably see? A 7 to...
8.5. It's the highest I've ever seen.
For a male, yeah. 7 would have to be a pretty small guy
Yes.
to have a 7 in. A lot of times anesthesia in the OR will put a tube in that's a little bit smaller than you would expect to see because it's easier to put in. And they're just there for the short term of the case. Well, the problem is they come back out of the OR and now we get them. And I have Matt here with a number 7 tube in. And he's breathing really hard because it's a small tube. So recognize that it's there.
What are the right numbers then?
Let's just go 7 to 8.5 for both, just to make life easy. I will tell you on our mannequins, I think we use 6, don't we?
Yeah, smaller ones.
Because you rip the shreds out of the mannequin, and they ain't easy to fix. I'll tell you that.
Would you feel comfortable asking that?
7 to 8.5.
Yeah.
Yeah, let's see now, you said.
Yeah. Probably the higher end for a male, lower end for a female. All right, so how do we go about putting this tube in? Well, we open the package that it comes in, but we only open it a little bit. So we're keeping the bulk of the tube sterile until we're ready to intubate, but we want to be able to access that 15 millimeter adapter, and we want to be able to access the pilot balloon. We check the cuff by inflating with 10 milliliters of air, making sure that it inflates and stays inflated. We can put the stylet in. The stylet's also in a sterile, sterile fashion. Making sure that, again, that it doesn't go out the distal end or the Murphy eye. We then bend it to make it look like a hockey stick. You want a little bit of curvature there. You can lubricate it with the sterile lubricant or that water-soluble lubricant or the xylocaine jelly so it slides through the process quicker. We won't do that on our mannequins, but you can. And let me just go through these and I don't know how well. I'll have to think of how I want to handle this. But there are certain airways that you shouldn't touch. There was a anesthesiologist by the name of Dr. Binion who came up with his Lemon Law. And the L was for look externally, E was the 332 rule. There's a classification system known as the Malampati. O was obstruction, and N was neck mobility. Let me just go through these, and we'll see what we want you to know. Okay. Somebody who is short, obese, and a fat neck. Not a good option. Okay. Somebody who has prominent incisors, buck teeth. Going to be a problem. Okay. Receding jaw. Somebody who has an underbite where the top teeth are over and they have a short mandible, So there's a huge overbite there. Or is that an underbite? I don't know. They don't match up. And some of those other ones make logical sense. And I'm going to let that go. There's our buck teeth. And there's our macroglossia, big tongue. Little Gene Simmons there for you. This is one you should be aware of, the 3-3-2 rule. When the patient opens their mouth wide open, they should be able to fit 3 fingers in. If not, I can't get the mouth open wide enough to put the laryngoscope in. You should be able to have 3 fingers from the distance from the hyoid to the mentum, so that this distance under my chin is 3 fingers. And the 2 stands for 2 from the floor of the mouth to the top of the thyroid as far as this distance here. So that's what the 3-3-2 rule kind of goes by. Okay? And that's an easy enough one to assess at the bedside. And there's the 3-3-2. Although 3 really is up here. Verse 3. Malampati, M. This was a classification system that said, how much of the throat can I see? If I ask you to open your mouth and stick out your tongue, how much of your throat can I see? Class 1, bitchin', everything's fine. I can identify the uvula very well, the soft palate very well, lots of space. 2, well, we're still not having it's not as good as a 1, but it's still pretty easy to intubate. 3, 4, yeah, 3 and 4 you shouldn't be touching. Call somebody who intubates all the time. Those are difficult to manage. And I'll tell you what anesthesia will tell you. We're not going to use our regular laryngoscope on these guys. We're going to go ahead and get some of our specialized tools because we know this is a problem. I have known anesthesia departments that have actually told patients after surgery, you are a difficult to manage airway, get a wristband or a necklace or something to say, watch out, I'm trouble. Is there any obstruction? That makes logical sense. If I got a patient who's bleeding, impaled objects, I like that one. Yeah. It's going to make it harder to intubate that individual. Neck mobility is the N in the Lemon Law, and that has to do with how easy that neck is to extend. And I won't get into this, don't expect you to get into this, just know that somebody who doesn't have a lot of mobility of their neck due to rheumatoid arthritis is going to be a more difficult intubation, and you probably shouldn't be touching them. Okay? What's that?
Here's your sign.
Here's your sign, yeah. So, we get our equipment together. We're going to put on our protective equipment. Assemble the laryngoscope and make sure that the endotracheal tube is working, functioning properly. Position our patients so they're in that sniffing position. Because remember, that's going to put the opening of the mouth and the larynx in a much more direct line, as shown here. You can use a towel or a pillow below their head to pull them into that sniffing position. You can see that if you just have their head tipped back, you may not have it positioned correctly. And this is just showing the same thing about how easily you can change the axes to be able to align them together so it's easier to visualize. Some of the anatomy that you have there, the tongue is what you're going to want to move out of your visual field. So you're looking through the pharynx, you can visualize the larynx once the epiglottis is pulled out of the way, either directly by lifting on it with a straight blade or indirectly by sliding it, the blade tip into the vallecula and pulling it anteriorly. This is the direction you want to use. Okay. I always explain it as, imagine yourself being at the bar. I know I'm stretching here for a lot of you. You have a mug of beer in your hand, you want to toast somebody across the table. That's the maneuver you want to have. The focus of action is pulling the mandible this way. What you don't want to do is pretend you're at the casino. In that case, you're using the teeth as a fulcrum and you're going to break them. Our mannequins are designed so they have a little clicker that's on there. We call that the Sam Bernstein clicker. They're going to call their plaintiff attorney. Okay. So once I do that and I pull that jaw anteriorly, I now can go ahead and have a direct visual of the larynx. Sometimes you need more than just a simple This lady would be one I would never even come close to trying. Obese, large neck, large everything.
Here you were laughing about the large-breastedness, that's where it comes into play. Because everything gets shifted forward. And now you're trying to put that tube down when you've got that much adipose tissue up right here. So it makes it a very difficult situation.
Absolutely. Curved blade, again, is sliding into the vallecula. That's straight. That's curved blade, yeah. And straight blade pulling up on the epiglottis directly. And again, we don't hyperextend infants. We're not worrying that much about infants. Going to pre-oxygenate them. Going to suction as needed, especially the oral pharynx. It's quite common, especially in a either a traumatic or a cardiac arrest situation, that there's secretions that have accumulated in the posterior oral pharynx. You need to suction them out. Possibly, if you have somebody who is somewhat awake and alert, you may need a topical anesthetic. If they are really making a hard time for you, there are ways we can control them also. We'll talk about them when we talk about pharmacologic control. There actually is a paralytic agent that you can use that's short-acting. It works wonderfully. We talked a little bit about this before, but again, it's a topical anesthetic. That's the key part to remember, associated with some other hazards. So it's not benign, so we try not to use it if we don't have to. Get the mouth open. We're going to hold the laryngoscope in the left hand. But Rick, I'm right-handed. I don't care. We hold it in the left hand. And that is because the visual component to it, if I hold it in my right hand, I can't see down the viewing channel. Okay? What's that?
I know, right?
Hold the scope in the left hand. We're going to put it on the right side of the mouth, and we're going to sweep the tongue from right to left. So we're pushing the tongue out of our visual field. Now that's on a human. On the mannequin, you can't do that. Because the mannequin, the tongue and the larynx are all one unit, and the larynx will be over by the left shoulder. So you don't need to sweep the tongue on the mannequin. But on a human, you will need to. We then begin the process of lifting the handle upward. We're not using the teeth as a fulcrum, and you don't want to bend the wrist. So you're going to keep everything straight in that fashion. That is a god-awful looking drawing of an endotracheal tube. Who the hell drew that? Looks like he's putting in a pipe. Good God. But left-handed, sweeping the tongue out of the visual field, coming in through the right side of the mouth. As he's sliding that blade over, you can then begin to see your laryngeal structures. You can see your vocal cords there, your epiglottis being pulled up at the top. Retinoid and cuneiform cartilage is visualizing there. Cool? Just like on TV. Once I visualize that glottic opening, that's what I want to be able to put it in. Okay? See that cords? I'm homebound. Well, if they're unconscious, or I'm sorry, let me rephrase that. If it's during a cardiac arrest, it's quite easy because they're dead and they open up. In most cases, even in a spontaneously breathing patient, as they breathe in, the cords are going to open. You just wait and time it, slide it in. Tube these. And it says, because despite amazing advances in medical science, your patient cannot yet breathe through his tummy. So we have to put a tube in somehow. That's a great picture of a It's actually upside down though, because here's my epiglottis. Cuneiform. When we would be looking at it, this picture would be turned upside down. Like this. Cords open that way. Use of cricoid pressure will facilitate dropping down the laryngeal structure. So one of the things that we will be, as an assistant to intubating, if you're not doing it yourself, is you can apply some cricoid pressure once they visualize the cords. Applying pressure on the cricoid with your thumb and forefinger, pushing down, drops down the laryngeal structures, facilitates viewing. Try it in the lab when you're going to intubate the patient. You'll see the cords, have somebody do cricoid pressure, and boy, they just drop right down nicely. We used to use it as a mechanism to prevent gastric distension during bag valve mask. That got pulled from the ACLS standards. I think it still works, but whatever. I don't count. So with the endotracheal tube in the right hand, put it into the mouth and along the right side of the viewing channel. Do not go through the channel. That viewing channel on a laryngoscope is for you to look through. You can't look and see the tube go through the cords if the tube's in the way. So you're coming up from the side like this and watching it go in. Once it gets a centimeter or two beyond the cords, deep enough. Now, of course, we're going to find people who insist on putting the entire tube and 15mm adapter inside the person's mouth. I'll guarantee you're probably somewhere in the lower right lobe. No, I'm kidding, but you're in the right main stem, definitely at that point. So here's the tube, pulling with the curved blade, pulling the tongue up and out of there, with epiglottis coming up also. He's going to slide that bad boy on in. Here's a view of the endotracheal tube. Here's the cuff going in. Once that cuff goes past the cords, you're in a good spot. During your next attempt to intubate, you observe a large piece of undigested steak blocking your view of the glottis. How do you get it out of there? Suction is going to be a hard time to get a block of meat out. McGill forceps. You are correct. All right. Once the tube has gone through the cords, are we done? No. Don't let go. What will happen if you let go? It will come back out. So you want to hold it. Okay? Put down the laryngoscope. In fact, what you can do is, as you're putting it down, put blade first, and it'll actually click itself off and save batteries. Hold the tube and remove the stylet. Let me say that again in case you didn't hear me correctly. Hold the tube while you pull the stylet out. If you pull the stylet out without holding the tube will come out too. Okay? Then we're going to inflate the cuff with air. How much air? Enough to make them stop going when you bag. It's a highly technical term. If you squeeze the bag, you'll hear the air leaking around the cuff. Put enough air in the cuff until the cuff stops that. It's called the minimal occlusive volume. We can ventilate, oxygenate, and continue. 30 seconds is how long you have to do this. If it's not accomplished in 30 seconds, bag the patient and try again. Okay? I don't know how many times I've been on a cardiac arrest and the internal medicine resident, it's 30 seconds, doc. I'm almost there. Well, if you were almost there, you would be there and we wouldn't be having this conversation. Get out of my way. I'm bagging the patient. It's like it's airways are difficult to manage. Once it's in, how do I know it's in? Well, I saw the tubes go through the cords. Really, I saw it. Well, okay, but that's not definitive. I can go ahead and see chest wall movement bilaterally. I can listen for bilateral breath sounds. Okay, I listen over the epigastrum and I don't hear sounds of air running into the stomach. Patient condition improves. That makes logical sense. I can pass a suction catheter through. That's what we'll do again once we get that tube secured. You can actually see condensate in the tube itself. Okay. Now, these are okay, but I will tell you that I saw condensation on the endotracheal tube moments before I saw a noodle coming up, because the guy had chicken noodle soup before and it was in the stomach. Or in the esophagus, I should say. Breath sounds. What do breath sounds sound like on a patient with COPD? They're diminished, aren't they? Very quiet. Okay? You're intubating, this is what I always use, the paramedic is intubating the patient on I-94. How well can you hear breath sounds there? Not very well. Okay? So really what you want to end up using, and we're going to skip through the esophageal detector device, you don't need to worry about it, but there is another mechanism out there, and we're going to focus on use of CO2. End-tidal CO2 is the gold standard, every intubation, every time. You should be able to see the presence of CO2 in the exhaled waveform, or exhaled gas. The colorimetric devices you may encounter, which you're seeing more and more is waveform capnography, especially during CPR. Mary talked about that, yes? Yes? Pardon me? No, not the color one. Not the colorimetric. Big Bird good, Barney bad. No. Capnography is the actual measurement of carbon dioxide levels. A tracing. Waveform capnography. So here we have our waveform capnography showing good ventilation, no ventilation, good ventilation. Okay? And we do have our end-tidal CO2 estimates that can be made, but again, the new standards call for an actual value, so you would have to use a capnometry. Capnometer is placed on an endotracheal tube to confirm placement. The end expiratory CO2 reads 0 as the patient is ventilated with a manual resuscitator. At this time, no one is performing cardiac compressions. What should the therapist conclude? And should conclude that it could be because CO2 is ventilation dependent. Yes? If I don't ventilate, CO2 levels won't necessarily become, let me rephrase that. If the tube is in the esophagus, I won't see any CO2 coming back up, right? So it's ventilation dependent. It's also perfusion dependent. If I'm not doing good CPR, I won't see CO2 either. Okay? We'll chat more about that in the fall. So that's telling me the tube is in the trachea or not in the trachea. What about depth of it? Well, I said I'm going to put it till the cuff goes past the cords, but 21 to 23 for an oral tube for a male, 19 to 21 for a female, so roughly 21 is a good spot to be around. Don't worry about peds. I give you the numbers there, but I'm not going to ask you on them. Chest x-ray only tells you depth. Doesn't tell you what tube you're in. Let me say that again in case you didn't hear me. A chest x-ray only tells you the depth the tube is in. If you're in the trachea or you're in the esophagus, they're going to look exactly the same way. Right? They're right behind each other, so yeah. Okay. If you really want to know if it's in the trachea or not, you can do a lateral neck x-ray, but no one's going to do that. And that radiopaque line can give us an idea. I don't know how well you can see it, but here's the radiopaque line. And here's my carina. Can you see the bifurcation?
Yeah.
So I'm a bit of a distance between the two. Tube should be somewhere, and you're going to get a huge argument from everybody on this one. This says 3 to 7 above the carina. Oh, man, I want to say Mary says 3 to 5. So for right now, let's just say 3 to 7, and she may modify that a little bit by making it a little bit shorter. Then we're going to go ahead and secure it with some waterproof tape. This slide, do you see the slide? You guys have the slide, right?
Yeah.
Okay. If I flex the head, I move the tube. As I extend the head, I move the tube. Okay? You can see that in a neutral position, as I flex it, I actually move it down, which is counterintuitive. Wouldn't you think if I did this, the tube would come out? It doesn't. It actually goes down. And as I do this, I actually pull the tube up. Okay? So movement of the head can make a difference. Why is this important? Because I'm in the ICU, we've intubated my patient, and here comes radiology in to do an x-ray. And it's a portable x-ray. And they're positioning the patient. Oh, your tube is in too far. No, my tube's fine. You got a lousy x-ray tech who didn't put the head in a neutral position. Okay? So it does make a difference. Securing it, I will tell you, you will go to 14 different clinical sites, you will find 14 different ways to secure an endotracheal tube. It's whatever that place happens to do. Everyone's a little bit different. People with beards, oh, aren't they fun? There's nothing to tape. Here I got the tape secured to the patient's face. Not present there. Okay? So we'll show you one method here. Recognize that there's a bunch of other methods that are there, some of which include mechanical devices. Look at the little baby's got a baby tube. That kid looks too healthy to be in there. We go through taping, don't we, the tube? What do we do?
Well, we do, but we don't really push it because there's just too many devices out there.
Right, so what do we use here?
We just have this Velcro thing.
Okay. One of the things you'll need to do is, once that tube is in, daily, doing as far as shifting it?
Every, depending on institution, it's at least once a shift.
Once a shift, okay. Which is 12 hours.
8 hours.
8 hours? Okay. So remember, if the tube is sitting here on the left side of my mouth, I'm putting pressure on my tongue. If I don't move that tube for 2-3 days, that's going to get awful ugly. So we want to rotate it to the opposite side of the mouth. And while I'm doing that, do some oral care. Okay. Murray spends a bit of time on nosocom and microaspiration and all that, oral hygiene. Okay. And there's our oral care talking about that. And they got really severe. Here's a look at that Yonker that has the little shroud on it. That's slick, man. Or, I don't know what they cost, but they ain't cheap. But you slide it down and the Yanker appears, and you slide it back up and it's got this protective sheath over it so it doesn't get dirty. That's sweet. Little oral care mechanisms, suction swabs. Yeah, way cool, man. Okay? Whenever you remove the tape from the tube, do not let go of the tube. There's nothing holding it in place but your hand. Okay?
Will we actually be doing
When you shave your patient, do not shave the pilot balloon.
They actually use electric razors now as opposed to
Safety razors. Yeah. We had a nurse, nursing assistant who cuts the pilot balloon on a patient twice in the same week. Linda, step away from the... But once we're done, we're going to go ahead and retape it. By the way, this tincture of benzoin, it's a solution that is yellow in color. Yeah, so make sure you don't get it near your white lab coat or your scrubs. It is nasty. What does it smell like? How would you describe the smell? It's a very sweet smell.
Yeah, you just know it when you...
You know when you smell it. But what you do is you can put that on the skin and it makes the skin sticky. Patients who you're intubating may be in congestive heart failure and diaphoretic. I need to have something that for that tape to stick to. So by putting some tincture of benzoin, you make that skin now sticky. Let it dry, obviously, and then the tape will adhere to the skin. Okay? Pardon me? Yeah, a little bit, but it'll wash off.
Wash off the skin, but it will not wash off the coat.
Been there. Well, it's like blood, yeah.
Isn't blood better than this?
Mary's going to talk about oral care and VAP in the fall, but I just want you to at least get in the train of thought of, even though an endotracheal tube has a cuff, there is aspiration of material around that cuff. Often it is stuff that is growing in the mouth that migrates into the trachea and around that cuff and into the lungs. That's the source of nosocomial infection. One of the things that's been shown to be beneficial is keeping the head of the bed up, but also doing good oral care. And who's in there doing oral care? Oh, the nurse will do it, right? Maybe not.
It is part of their requirement, but it depends on the institution. There's a lot of institutions that respiratory methods, so.
That's right. All right, I'm going to skip through that one. As far as extubation is concerned, when we don't no longer need to be ventilated or oxygenated, we pull it out. When there's good secretion, think of all those reasons why we tube somebody. If they're all been relieved, take the tube out. Okay? This is just talking about, again, why you would want to extubate the patient. There is something called a leak test. Okay? And it's basically a test where we assess for upper airway edema. If I have the cuff deflated, can I still move air around there? Okay? If not, the trachea and the laryngeal structures may be swollen. You really don't want to pull the tube out because they're not going to manage well without it. So are they ready, and is everything in line as far as a protocol in place? Did I mention about having a bag valve mask system handy? No. Okay, yeah. You'll need it. Go ahead and you're going to have that syringe handy, something to remove the tape. I don't know if vapenephrin bedside or not, but you certainly have it close by. Yeah. Explain to the patient what's going on, have them in a high Fowler, deflate the cuff, I'm sorry, suction above the cuff, suction the tube, suction above the cuff as far as the oral pharynx, suction, deflate the cuff, do that leak test. And this is kind of what it's looking at, listening. That's an awful looking guy. I think he's in our lab. No, that's not Tranny Annie, that's the innovation mannequin. But he's listening for spontaneous ventilations around the tube while the tube is occluded. Can you see his thumb? His thumb's over the endotracheal tube.
Yeah.
So what he's doing is he's having the patient move air around the tube. If he had a laryngeal swelling, you wouldn't hear air moving.
That doesn't occur often enough in my...
Oh, I agree.
It's very rare you see that done, but I have had one instance where I could not hear air pass around the cuff, and the doctor told me to extubate. Don't worry about it. I said, I'm not. I can't hear any air. He came in and he said, oh, I hear it. And I said, okay, then you pull it because I'm not pulling it because I really don't hear it. He backed off, and the lady ended up remaining intubated for the next 3 days because they couldn't pass that leak test because she had so much swelling around the port and stuff. She was an angioedema patient, and it was like,
Oh, you're begging.
I'm not pulling. You want to? You pull, but I didn't want to because I knew I'd be reintubated.
Good point.
And I don't think so. It is something important.
So we're going to remove the tape, put a catheter, suction catheter through into the tube. When they're taking a deep breath, in other words, the cords are open, go ahead and, if you have the suction catheter, apply suction at that tube and pull the tube out while you're pulling the suction catheter out. And then the patient will cough and remove any other secretions that are there. And just monitor them. They'll probably need some oxygen therapy at that point. do your regular assessment. Do they keep NPO for 24? I don't think so either. It's an old slide.
Depends on the issue.
Yeah. Look at your complications we talked about earlier, as far as having laryngeal edema, and you'll hear that stridor. You'll know that you've got issues going on. And if I have a lot of stridor and a lot of distress, that's really an indication to re-intubate. I don't have the airway that's open. I can try doing racemic epinephrine if it's not very severe to reduce the swelling. And certainly if they're just got a sore throat or hoarseness, and again, depends upon the duration of intubation, I can certainly just give some humidity and some racemic epinephrine treatment to reduce the swelling. I'm skipping through these, Okay, do we need to take 5?
Yes.
All right. Got it. You guys got to stop me. Cuff pressure monitoring. It's key to be able to monitor the pressure within the endotracheal tube or tracheostomy tube's cuff, because that pressure is directly transmittable across the wall, and tissue damage can be minimized if you keep pressures at a proper place. The ARC's guidelines, and you'll see a little bit of difference and variance in this, but 20 millimeters of mercury or 25 centimeters of water. Those are equivalent values. And I want to do the math on that. 20 millimeters of mercury, 25 centimeters of water. That's what the cuff pressure should be. Depending upon what the manometer's scale is, you're going to have to know both. Most of them, I think, are centimeters of water, but knowing your luck, we'll pull something different for the PE just to drive you crazy. If I have pressures greater than 30, I obstruct arterial flow. Pressures greater than 20, I obstruct venous flow. And really, we can't do much about lymphatic flow because you need to get some kind of seal in the process there. Okay, we want to minimize the amount of tracheal wall pressure that is being applied by the cuff. So we're going to keep it at 20 millimeters of mercury, 25 centimeters of water. These are what the cuff looks like, and again, we primarily see the high volume, low pressure cuffs, which are these. The reason why these are low volume, high pressure is because as they inflate, there's only a small spot where the cuff hits the wall. That means that there's a large amount of pressure at that one spot that promotes that tissue to deteriorate. Okay? You can see the cuff sitting there, and you can see how easy it would be for that to erode through that wall. The method that we're going to utilize is what is known as the minimal occlusive volume technique. We're going to put just enough volume to occlude. Okay. So we're going to use a manometer to measure the pressure, a stopcock, we'll explain what that is, and a syringe. Okay. Lots of other devices that are out there. I think Mary covers some of them, like the Lanz tube and some other stuff in the fall, but for right now, we're going to just do the simple technique. So during positive pressure ventilation, we basically put enough air into the cuff so that we don't have any leak present. Put enough air in to make them stop going.
How do you spell that?
Okay. So basically what we're going to do is we're going to have it so that there's no leak present. We're going to put enough air in. We're going to then deflate the cuff until there's just a small leak, and then put a small amount of air back in until the leak goes away. Does that make sense? I put air in so there's no leak. I then remove air until I just hear a squeak, and put air back in again. You can listen audibly. More often we'll put a cuff on, or a stethoscope on the neck and listen for the leak to be eliminated. At that point, then we're going to measure what the cuff pressure is, because that's the proper amount to just seal the trachea.
So if you get to the point where you're above the 20 centimeters of water, is it safe to say you need a new balloon?
Well, that's the. I think I might talk about it in a second, but that's the point at which we contact the physician and say, hey, your cuff pressure is 30. And he says, well, there's not much we can do about it. Okay, thank you for calling. I document it. I've done what I can. Ideally, yes, the tube should be changed out and the larger tube put in. If I put a 7.5 tube into you, you're a big guy, chances are that's not going to seal very well, because the tube to trachea ratio is not appropriate. So you're going to use a lot of pressure to get that to seal. Now, it's probably not the best option. Get a bigger tube in. Okay, deep breath. This is what a stopcock looks like. Okay, it has 3 ports, one going this way, one going this way, one going this way. It also has a valve. The valve has different positions. If it's pointing this way, this one's turned off, and these 2 are open. If it's pointing this way, these 2 are open, and that one is off. If it's pointing this way, these 2 are open, this one's off. Some of them you can even turn it so that it's at a 45-degree angle and they're all turned off. Okay? This little tab, if it's pointing up, that's closed. Here it's closed. Here this is closed.
So does it just turn?
It turns. Okay? So I want to set it up so that it's like this: a syringe on one of the ports, my manometer on another one of the ports, and the endotracheal tube cuff on an opposite port. I want to have the stopcock off to open port. Oh, I'm sorry. Attach the 3-way stopcock to the syringe and to the manometer. So right now I don't have this hooked up. Okay? This is turned off to here. Make sense? So it's open here, closed here. Okay? I then have my syringe and I inflate and pressurize this to 25 centimeters of water or 20 millimeters of mercury. I'm priming it. I'm creating a pressurized environment here. I then, with the stopcock off to the manometer, hook up the pilot balloon to the stopcock, and I go ahead and I do the minimal occlusive volume. As I just said, I had inflated it till it's silenced. I then removed air by pulling back on the plunger of the syringe until I have just a little bit of a leak. I then reinflate it again. So off here, and I'm using the syringe to create that minimal occlusive volume. I then turn the stopcock off to the syringe, which means it's open from here to here. I now measure my pressure.
You're going to show us this, right? Grandpa?
No, I'm going to take a PE on you right now and see if you can do this. Okay. Again, if we're above that safe range, that's where we need to troubleshoot and notify the physician. Okay. Once I have my measurement, I just remove the pilot balloon from the stopcock. The pressure that was inside this is maintained, and I have my seal present. So again, this is what it's looking like. Pressurize it, because it's off to here. I moved this down here so it's off. I've now pressurized the manometer to 25. I hook up my tube, and I can now go ahead and, that's drawn wrong because that should be at 25, but I can now create the minimal occlusive volume, and then I go ahead and I measure. There is something called a cufflator, which is really kind of a lazy man's way to doing it. Doing the same thing, but we're basically hooking our stopcock up to here, and we're able to inflate and deflate. This is when you kind of really play with to be able to do. If I did have a pressure that was too high, make sure the tube's in the right spot. It's one of the big things. Yeah.
So my question is, so first you decide the volume that you're going to put in, and then you change the pressure depending on...
First I put enough volume in so that I have a minimal occluded volume.
Right. And
Then I measure the pressure at that volume. Okay. Could also be the tube is, the cuff is malpositioned. Sometimes deflating it entirely and reinflating it will be able to inflate more proportionally. If you think about that cuff, it can have situations where it inflates more on one side than on the other, and sometimes that can lead to erroneous cuff pressure measurements. And we talked about a larger tube might be needed, and we'll talk about different types of trachs in a bit. So in the fall, Mary's got all kind of wonderful stuff to continue on. High-low evac, Rick Cole ray tubes, endobronchial tubes. Oh yeah, baby. Gum elastic bougies. Not dimey bougie, that's something else. Okay. Whole truck full of Black & Gus's. Scary. All right. So let's talk about the artificial airway. Suctioning, the indications are pretty much what we've talked about prior. Whenever you hear those audible sounds, you hear rhonchi in the airway. The patient isn't having an ability to effectively cough on their own. If they're intubated, they won't be able to do that because you've got a tube to the vocal cords and it can't build up pressure. So we will also then go ahead and suction when we need to get a sputum specimen, and that's where we'll finish up on talking about the Lucan's trap to be able to accommodate that. So what equipment do we need? Same kind of stuff we've been talking about previously, as far as a suction regulator, a vacuum source, sterile water, a disposable kit. Again, that's the open suction kit that you're going to end up using. Now, mentioned earlier about measuring sizes. I was talking about airways as far as nasopharyngeal airways. This is more important right here, and this is the rule I want you to follow. And it's that one in red in the middle. Okay. The inner diameter of the endotracheal tracheostomy tube, multiply that times 3, then divide by 2. Now, the reason why is to convert from millimeters to French size, you multiply by 3. So if I had a 7 millimeter inner diameter tube, that's the same thing as saying I have a 21 French. Hold on. Multiply by 3 to convert millimeters to French. But I don't want to have the full size. I only want half that value. So I divide by 2. And then you go down to the, if it's not an exact number, go down to the next lower size. So if I have, let me see if I got an example here, but this is basically what it's talking about is, I have this diameter of suction catheter, I have this diameter, inner diameter of endotracheal tube, it's an 8. Okay, I need to have something less than that. So a 6 millimeter, making it into French would be 6 times 3 is, divided by 2 is, but there is no 9, so I use 8. Got it?
So you use the same size for 17 like.
Yep. It's not until I got to a 7.5 that I can go to the next size up. Okay. So that open suction we talked about before, as we demonstrated, you want to pre-oxygenate Do all of your monitoring of the patient. How much vacuum do we use on an adult? You think you're going to see a question like that?
Yeah.
1,001 times over. How do I evaluate that? With the tubing occluded. That's the part people fall apart on. They set it to 100, 120 without occluding the tubing. So you really don't know how much is there, and then you occlude it, and all of a sudden you got 220. Okay, you're going to maintain sterility. Open the sterile water first, or sterile saline first, that you're going to use as a rinse. Open the kit in a sterile fashion. Wasn't that fun? Takes a lot of practice. So, just to warn you. Using sterility, open the basin, catheter dominant hand, and then you're going to waste one of the hands, make one of them dirty by opening and pouring the saline and the sterile water into the basin, and you're going to verify the function then. Saline installation, recognize that some people say it helps mobilize the secretions, other people say it's bunk. So some places will have a policy that if you're having thick secretions or you're having difficulty suctioning stuff up, instill some saline down the endotracheal tube. Other places say don't do it. So I can't give you an answer confirming one way or the other. This is what they're talking about, small amount of saline down the tube. This is just continuing on with the source as far as, or suctioning protocol. Just like we talked about earlier, no vacuum on the way in, only suction on the way out. No more than 10 to 15 seconds of vacuum being applied. Okay. This is just talking about on children, you can end up using the centimeter markings on the suction catheters. The adult catheters don't have those, but the neonatal catheters do, so you can know the length of the tube that you have and how far you need to suction, how far that catheter needs to go down. And that usually is something that's noted by the bedside. Post-suctioning and oxygenate, and then get rid of your equipment and document. Same contraindications that we talked about previously, and you need to, it's, again, there really isn't any complications or contraindications per se, because if you need to be suctioned, you need to be suctioned. If you're actively bleeding, but it's occluding the airway, then you still need to suction and get it out of there. Some other hazards and complications, I like the little ha-ha. Hypoxemia, arrhythmias, hypertension, atelectasis. Pretty much most of them are common sense things. Interruption of mechanical ventilation and interruption of PEEP. We'll talk about, when we talk about closed suction systems, it's one of the reasons why on mechanical ventilated patients we don't use an open suction technique. The ones we were practicing this morning, we don't do that on a vented patient. Simply because you break the PEEP. And that can promote de-recruitment of the alveoli. Skip through some of the things assessing that. You know, the bottom line is you're sucking air out of them, so you want to make sure that you're hyperoxygenating prior to the procedure starting. And then after the procedure also. All right, let's talk about closed suction. This is one, again, that we're going to be leaving in line. We break the system once. In fact, we don't break the system. We put this on before we even put the patient on. It's in anticipation of the ventilator being used, we go ahead and attach this to the ventilator circuit. We don't have to disconnect the patient anymore, rather that catheter is inside a plastic sleeve. And this is what it looks like. You can see the catheter coming out here. Here's my vacuum source, here's my thumb control. As I press on that, I create vacuum to be applied to the distal tip. Okay. There is a saline port where you can instill saline for those who want to do it. Whatever. Hardest part is figuring out how to attach this for the ventilator circuit. Here's my suction, so this is going to be where my endotracheal tube hooks up. This is going to be where my ventilator circuit hooks up. So as I'm ventilating my patient. I go to suction, I just push that suction catheter through. Okay. And there's a cap port on this side so that there's no air leaking out there, but if I had a patient, say on a T-piece or something, I could end up using this also. Should know that we use it with unstable patients with high ventilating pressures, high levels of PEEP, very unstable oxygenation status. Can also be beneficial in those patients who using open suction, you end up having dramatic drops in FiO or in PaO2 to desaturate quickly. Okay. When it first came out, we went through all kind of cost analyses to see, you know, are we really saving money and whatnot? And pretty much now, I don't know of any place that isn't using closed suction anymore for vent patients. It's just been shown to be so much more beneficial. We also use it for when we're inhaling specialty gas mixtures like Heliox and nitric because it's so expensive to keep that gas. You don't want to lose it to the atmosphere. DFU, if you've never heard of that term, means directions for use. What a novel idea, reading the directions. But they all come with the directions that you can go ahead and... I don't know if I blew them up for you in the back or not, but they're there. So same idea going on as far as pre-oxygenating, monitoring the patient, putting the suction at the proper level. You don't need sterile gloves because it's not a sterile procedure, but you should have just non-sterile gloves on. And we're going to go and apply or insert the catheter without suction being applied. Once you meet a spot where the patient starts coughing, we're going to go ahead and withdraw the catheter, then begin to apply vacuum pressure as we're pulling the catheter out. And this usually just pull it straight back. The hard part is learning to hold the end of the catheter where it's attached to the endotracheal tube and pulling back. Because if you just pull back, the tendency is to disconnect. Okay. Once it's drawn back completely, we're going to go ahead and use some of those saline packets to rinse the catheter. You don't have the ability to put the catheter into the little basin to clear it out. So what we do is we hook up the suction packet or a saline packet to that installation port, and as you squeeze it, it'll go ahead and flush the catheter out. And then go ahead and post-oxygenate. Most of the models have a mechanism by which you can lock the thumb port. What you don't want to happen is you're done suctioning, you walk away, the patient rolls over and rolls onto that thumb port, and all of a sudden there's vacuum being applied at their airway. So there's a way that you can, by turning a lever or what else, flipping something, you lock it out. Yeah.
For the pre and post oxygenate, do you do it with a bag or do you just...
Put the ventilator, yeah, you'll find that all the ventilators have a 2-minute 100% oxygen button. So you push that while you're getting yourself ready, go ahead and pre-oxygenate, do your job. When you're done, push the button again. And it'll automatically increase the FiO2 to 100% for 2 minutes and then go ahead and drop it back down.
What if they're not ventilating? Or ventilating? What if they're just intubation?
Oh, what if they're not on a ventilator but are just intubated?
You don't usually need a 24-hour catheter.
Yeah.
You can still bag them.
Unless they have TB or something, we normally don't use a closed.
If one unit is open, do we want to oxygenate?
You can use a resuscitation bag. Give them some deep breaths with 100% oxygen. Ain't that fun doing it by yourself? Huh?
You get good though.
You get good at it, that's right. Oh. Okay, I'm going to skip through the practice on this and go to some other issues. Let's do another quick movie since I have it.
Ew! He just caught a fish, a bass. I don't know, they're spelled the same. Guess where he took me? Fishing. Yeah, fishing. Water and everything. Oh, I know, they're so yucky. He almost made me touch a worm. Oh. He took fishing, so I thought we were going on Daddy's yacht and getting sushi. Well, he is cute, though. You should see him in his little fishing outfit. But whatever. Look at me. I worked out yesterday at the gym. Treadmill. 3 minutes. Almost worked up a sweat. All I know is when we get back to dry land, eBay. Me or the boat. Of course it's going to pick me. I don't know, the boat's kind of sparkly, though. My outfit matches it, and I did not even plan that. That's so funny. I'm not another guy that doesn't take me fishing. I know.
Let me skip through these. Just get to the part where... Here we go. Specimen collection. So when we do... Oh, God. Yeah, that's not the way to collect specimens. Yes. I'm going to use what's called a Lucan's trap. And again, it's something that is placed between the vacuum source and the suction catheter. Voila. So now as I apply vacuum, the specimen is collected here, and I can send it off to the lab to be assessed for, microbiology and culture and sensitivity, etc. Okay. Now here's the trick. We're going to do this. We're not going to do it with a closed suction system. We're going to do it. Do you guys do it with the closed for the first time? And then you use.
Yeah, only if it's a brand new closed suction you use with Lucan, otherwise
it's already been contaminated. Yeah, it's open. So what you guys are going to do is when we do the open suction PE, we're also going to have you attach the Lucans, do a pass with the Lucans, collect the sample, then detach the Lucans and reattach for another pass, all while remaining sterile on one hand. That's the trick. But you can do it. It's a learned behavior. Okay. We be careful with instilling saline. Some of the saline is bacteriostatic, which would kind of defeat the purpose of your sample. So we're going to have you do it without any kind of installation is involved. Once we collect our sample, we're going to go ahead and label it, biohazard bag, place on ice, and transport to the lab. So let me go over and let me go over and we'll show you how to do this. We'll break for the day, and then tomorrow we'll come back and start off in the lab having you go through the sample. Huh? Did you say I tortured you?
Are we going next door?
I didn't hear you. Say again.
Is our quiz just on AIM?
Yeah, it'll be just on Module A. What we covered today and tomorrow. Wednesday.
All day, right? When is it? Wednesday. I'm like, Friday, right? Friday. I didn't take my quiz. Today? Check out. Doctor has left the building. I feel like the only two failed should feel sorry for us. Okay. Come on, John, let's go. Good?
We didn't get anything accomplished.
Oh, I know.
A lot of stuff was,
I know.
that was a waste of time.
favorite part. That's my favorite part.
Yeah, I feel like it starts at like fucking 6.
Yeah. Oh, it does. Yeah.
It's ridiculous. I don't cook for dinner. I don't drive anybody anywhere. He's on his own.
And he's okay with this?
Yeah, he's thinking that I'll make money. Can't wait to go hire down in Arizona. I'm like, how much do you think it's going I'm nervous about where I live though. Yeah. Nope, Charlie, you cannot go. Yeah, no, I'm not nervous about no, just
Get up early?
Yeah. Impossible.
First thing you do.
And they don't have latch. Yeah, I know. So you don't think I used last year's notebook?
I know you're not talking to me. I need to get out of this.
I'm kind of
I think I'll send that to you. I'm so short-sighted.
There is a new chapter now, but I don't know what else the modified new chapter.
You said it's the same year in and year out, right?
Say what?
You said it's the same year in and year out. So
Well, my first started.
Alright, that's it. Alright, I have last year's workbook, but I have this year's lookbook. I think I can get away with it.
Yeah. You told me to go and try to grab another card.
I think that's it. So did you have to fire?
You did it so long. So long. Okay.
You're talking all of it.
No, I think I could do that. I can handle that.
No, you can't.
I know I can't. Just saying.
My wife wonders what's wrong.
Oh, you're all like that, whether you talk all day or don't.
I know. You guys are all like that.
Exactly, that's why chromosome, that has nothing to do with your job.
You're the worst at this. Lawyer.
She's a lawyer too. What does she want to talk? Does she talk all day too? She's a woman.
She likes to argue.
Shocking.
Never heard of a lawyer that's
Not
right wins too.
She's been getting into doing appellate. So,
What is that? Is that,
What is that?
that's,
if somebody wants to appeal an existing decision,
yeah.
Okay.
it's almost a separate lawyer. Well, it usually is a separate lawyer you go to because not all lawyers want to venture down that road.
I've seen, yeah.
She's going against like a precedent, or she's showing evidence. That this is wrong.
She's taking cases that don't have clear law,
What kind of lawyer? So nothing's written, so it's all her, and then she's going to get published.
and she's actually been published
That's what I'd want to do if I had.
that where she's made new law.